All right, everybody, let me start the introduction. This is Dr. Jackie. I've met her several times. Fortunate enough to work with her with one of the families that I work with. And so she is familiar with children with hearing loss. She's also familiar with adults with hearing loss. And so she has some expertise in that area. Dr. Jackie, just for your information, about half of our group here works with children who have hearing loss, and the others just work with children that have multiple disabilities, but they don't have the hearing loss component.
Okay.
So I'll let you introduce yourself, and then we'll just take off from there.
Okay, I'm Jackie Hall Davis, and I'm a child and adolescent psychiatrist. I have been in this area since about 1992. I finished my residency and fellowship at St. Louis U. I went to med school there too. I grew up in St. Louis, but I went into the Air Force at Scott Air Force Base. I was over there, and then I stayed in the Illinois area. I'm employed at Chestnut, which is in Belleville. It's a mental health clinic. I see kids and teenagers, but I always joke because my oldest client is actually 73. And she is someone who continued with me through the Air Force when I saw her there, and she just continues to come see me. But I've also have a number of children that have grown up with me, and so now some of my children are married, adult, and have children of their own, and I have about a handful that I see their children now. So that's really interesting because I don't like to think of myself as being that old, but obviously I am. So, and these are not adults who are in their 20s; they're in their 30s. So I've been seeing them for a really long time. So I know this is going to be really informal. So I first want to find out what area. Where are you guys from? What area? Northern Illinois, where?
Jacksonville, Illinois.
Johnsonville?
Jacksonville.
Jacksonville, okay.
Southern Illinois.
Southern Illinois, okay. Marion, Carbondale?
Carmine.
Carmine, okay, yep. Are you at the Baptist Children's Home?
No, we're there, but we're not affiliated.
Okay, okay.
We are south of Marion at the bottom of the state.
Okay, all right. Any child psychiatrists in that area? Where is there a Simeon Greater there?
They Skype them in from
They-
Chicago,
ugh.
in Faro,
Okay,
and then there's one in Vienna.
okay,
Child sometimes, so he's just a regular psychiatrist.
okay, but not a child, okay,
There's
all
one
right,
out like Aaron,
okay.
A question too. ISD for a while did a Skyping with a psychiatrist. What's done now with the psychiatrist for
We
ISD?
still do VP psych, some. Or at least at the high school level, I don't know what they do at the other levels.
So they're still doing the videotaping psychiatry too.
Okay, yeah, we have one psychiatrist who does that. I mean, actually where I am, I'm the only child and adolescent psychiatrist. We have 2 nurse practitioners that see children, and then there is Dr. Chu was doing some Skype, but now they have someone else, Dr. Lopez. I have never met her. So what I want to find out from you guys, initially, without questions, what kind of things are you interested in? Is this medication, certain types of medication? Give me an idea.
I'm in the medication.
Medication in general for children and adolescents, right? Any particular depressants, mood stabilizers, ADHD meds?
All of
Just
it.
broadly.
We serve the school district the school that we're in. We serve several students, and they all have they're severe and profound, and there's probably a handful that are not on some form of medication.
Okay, okay,
And so we have, you throw a drug out there, we probably have a kid on.
okay, all right. So let's do this. Let's do with the most common ones that typically children start off with, which would be what category do you think? ADHD. Okay, so there are what I like to call 3 categories, A, B, and C. A and B go in together in terms of stimulant medication. Okay, and one of the things that we talk, I'm sorry, I have to take this off the drag now. That the stimulants do not necessarily stimulate the brains. I have kids come in and say, is it going to make me hyper? That's not the goal. The goal is neurotransmission. Anything we do within the brain deals with the neurotransmitters that are up here. And so I tell the kids, no, what I want to do is improve your ability to focus, attend, concentrate, and not be so fidgety, antsy, impulsive. So I want to address certain chemicals that are up here. right in the front part of your brain. And I always slap my forehead and say, this is where I want them to work. The executive functioning. You may have heard that term now, the executive functioning. Well, that's just a fancy schmancy way of calling ADHD. It has to do with processing and learning and your working memory and using good judgment and making good choices. And so what we want to do, we want those meds to work there in this area to deal with dopamine, norepinephrine. So give me some ADHD meds. Ritalin, Adderall, Concerta, which is, Ritalin and Concerta are in the same category.
Are they?
Yes, they are. Give me another one.
Meditate.
That's in the same cat. Okay, give me another one. Vyvanse. Focalin XR, Focalin, Metadate CD, Ritalin SR. So we have A and B category. The A category are the methylphenidates. Okay, and so they come in every shape, size, and color. And they can be called Ritalin, Ritalin SR, Metadate CD, Methylin, Methylin ER, Focalin.
You might go a little bit slow.
That's what I was wondering.
Thanks.
Sure. Okay, Focalin XR, Concerta. Let's see if I left anything out. Oh, Quillavant. Quillavant is a liquid methylphenidate. It's brand new. If you have public insurance, you're probably not going to get it. And then you have the Daytrana patch, which is also methylphenidate in a patch form. And the kids wear it on their hip, alternate hip to hip. So those are methylphenidates, okay? Those are stimulants, but they're methylphenidates. Then the other category of stimulant medications are the amphetamines. Adderall, Adderall XR, you have Vyvanse, Adderall, Adderall XR, Vyvanse. And the old one that people talked about was the dexedrine. But we really don't use dexedrine. Very few, very few. And then there's a very old one that the side effects were, they seemed to be more potentiated, and it was called Disoxin. But you probably haven't heard of that because we don't, have you heard of that one? Yeah. So we don't use that anymore. So those stimulant medications have the same set of side effects. What would those be? Think about a stimulant. Think about caffeine. Think about nicotine. Weight loss. Jittery. Sleep, appetite, therefore weight loss. Headaches, stomach aches, irritability. Okay? So the medications on the positive end allow kids to attend longer, sustain their attention, have more attention to detail, not be as distracted or off task, not be so antsy and fidgety, but they can also do the opposite. So if you can't tolerate caffeine, your heart races, you may feel hot, sweaty, jittery, irritable, you may have a headache, may not be able to sleep at night, your appetite may drop. So those are things that you're going to be looking for, and sometimes we're kind of tricked because as we start to treat kids and then we see the symptoms maybe improve a little, but then they seem to not work, we increase the medication, and all of a sudden you have an irritable, moody kid. So the potential is that then you created a mood disorder, or they already have a mood disorder that's just been then accentuated. So you have to be really careful with that. Your category C of ADHD medications are the non-stimulants. They're not controlled, so they don't have to have a paper script every time they get it. The stimulant medications, the control medicine, cannot be called into a pharmacy. So if the parent doesn't have the script, they miss the appointment, they don't get it, then it's out. And it doesn't hang on. It's a day-to-day medication. The non-stimulants, on the other hand, sometimes can sustain over, and the side effects are different, maybe better tolerated. Anybody know any non-stimulants? Yes. There are two other ones. Clonidine. And there is a branded product on the clonidine for ADHD. Anybody heard of that? It's called Capvay. It's an extended release clonidine. And then there's one other one that's very similar to clonidine. It's Tenex or guanfacine. And then there's a branded product called Intuitive. So if I go to my doctor and say I have high blood pressure, he might give me guanfacine or clonidine. But if my kid goes and says I have ADHD, they might give my child Cat-Bay or Intunic. But it's the same thing. And it's just a branded product that's marketed for ADHD.
And giving them both at the same time?
You cannot, well, in terms of, what do you mean giving both?
My boy, when he was little, they gave him clonidine during the day. No, they gave him Concerta during the day and clonidine at night.
You can do that. You can do that. And I'll get into that, but that can be done. If you can use them as a single agent, it's nice, especially with Strattera. But the bad thing about Strattera, most kids can't tolerate the GI problem. They get very nauseated, stomach upset. Sometimes their appetite decreases, but it's primarily because of the nausea. And then some of the kids get real sleepy on it. The clonidine can be more sedating than the guanfacine or the 10X. The 10X is nice. Those two agents deal with norepinephrine, so you can decrease impulsivity, irritability. You can also help focus if they're not sedating. So what happens is you can use a stimulant and a non-stimulant together. And I tell kids it's like an orchestra. It all plays together, it works well together, because one agent is going to kick in 30 minutes, 45 minutes. It's going to taper off depending on whether it's a short-acting, a mid-range, or a long-acting. And then your non-stimulant, hopefully as it's built up in your system, is going to be there to kind of be a buffer and to manage some of the other symptoms that are not completely taken care of. So you can do that, and it's designed to do that. What kind of questions? Yeah, okay. Oh, you didn't follow instructions.
We're raising our hand, right?
What is the difference between clonidine and clonopin?
Okay, you have to be careful with the spelling. That's one difference. Okay, clonazepam is Klonopin. Okay, it's a benzodiazepine. It's for anxiety.
Okay.
Okay, clonidine on the other hand is an alpha agonist. That's a structure that's for blood pressure control, but also used in kids with ADHD to decrease impulsivity, hyperactivity. Now, one of the things that you have to be aware of with kids who take the 10X or the clonidine, you typically do not get the blood pressure drop, but you have to monitor it because some kids will say, I feel dizzy, I have a headache, I feel sleepy, and when you check the blood pressure, it may be a little low. The other trick here with the stimulants versus the non-stimulants is that you cannot just abruptly stop, or should not abruptly stop the non-stimulants, because the kids are going to have some rebound. The theory in terms of stimulant medications, drug holidays, it varies depending on parents' compliance, on the physician's thoughts about that, and then how well the kids are. Some of the kids I see who do very, very well and really are only the ADD type kids, they use it during school. But they seem to do pretty good during the summer, even driving, even at work. But some of those other kids that are more impulsive, more reactive, don't have real good control, don't have real good executive functioning, really should be taking it every day. And so you sometimes don't get that. The theories long ago, when I first started, some of the kids, I think the dosing, and we have so many varied products now, but the kids were on high doses, and so they had side effects. And so they needed to feed and grow because they didn't eat, they didn't sleep well. When they would eat, when the medicine wore off, late at night, so it was problematic. And so these kids really needed to catch up. And there is still some concern with high-dose stimulants, whether or not it can really affect the growth rate to some degree. So you have to be careful with that. Any questions about the ADHD medication? Because this is pretty, yeah.
Are there any ADHD medications that also help with mood? Like mood stabilizer?
No, not really. Strattera was created initially, the atomoxetine, that generic molecule, the generic name atomoxetine, they attempted to use it for depression and anxiety, but it wasn't robust enough. So it was sort of repackaged, but they found incidentally there were some improvement in attention and focus. So that's how that came about. So there are some kids who do have some anxiety that it seems to help with, but it's not an agent that I would use to treat mood. And as a matter of fact, if you look at the warning, sometimes it can exacerbate a mood. The kids that I see who may have a secondary cyclic mood disorder, sometimes it can make them a little bit
So you would do
hypomanic.
2 separate medications?
Now, here's the key. If you have a child with a mood disorder, whether that be some type of intermittent explosive disorder or bipolar disorder, and now they have a new category in the DSM-5 is a dysregulation disorder, where more kids seem to really fit into rather than truly having bipolar disorder. Those stimulant medications can sometimes swing that mood up. It can make them more irritable. So you really need to stabilize a mood disorder before you use an ADHD med, but you can do that. Any other thoughts or questions about the ADHD meds?
Yeah, with ADHD and the medicine they use for that, whenever the girl would get near her menstrual cycle time, she tends to get out of control, the student we have. So can the medicine really disrupt her mood when it gets close to menstrual?
You know what,
cycle?
that's a good question, but that is actually medicines we would use from another category, the SSRIs, antidepressants. And so the ADHD meds don't directly affect that, but it sounds like she may need to be treated with an SSRI to stabilize that premenstrual time frame, serotonin agents. And so
That's about SSRI. That is.
yeah, I'm going to talk about that.
Yeah.
Okay, so then the next category that we go to with kids most commonly, and I said SSRIs, what are those? Anybody know? Everybody's like,
Reuptake inhibitor.
Yeah, I'm not sure.
selective serotonin reuptake inhibitors. Do you know what those are?
They'll lost it
Yeah.
every time.
Selective serotonin reuptake inhibitors. So somebody said Zoloft, Celexa, Lexapro. What's the old daddy? What's the oldest one?
Prozac. yeah.
Prozac. There you go. Right. So you have a group of medications that have either been grandfathered in or actually have been studied in children. Prozac has been grandfathered. It's been used for years. Children, that was the first one we had used with kids who had autism. The perseverative, obsessive kinds of behaviors. You have Zoloft. You have Paxil. You have Celexa. You have Lexapro. And you have one called Luvox. Anybody heard of Luvox? Not a lot of people use it, but Zoloft and Luvox were actually the ones approved for children with OCD, 7 or 8-year-olds. And so those were the targets of those early drugs when they first come out. Those were the targets. Paxil is not used a lot in young kids. It has a lot of side effects, a lot of GI side effects. So kids get really nauseated and sleepy. You have kids on those medicines. Familiar with those? The most common ones that are used are typically the Prozac, Zoloft, Celexa, Lexapro, again, not the Paxil or the Luvox. And even though they are from the same family, they are a little different. And so that's what makes it nice. Some of them are more activating, energizing, alerting. Others can make kids feel more tired and more sleepy. Sometimes it depends on what you're really looking at treating. Prozac is very good in treating also eating disorders, bulimia. So that's also a target for the Prozac. Luvox is used more in Europe for depression, and it's sedating. So if you do have a child who has a real strong OCD symptomatology, high anxiety, but can't sleep, that may be a nice option for them. Commonly you'll see Zoloft and Celexa or Lexapro. Celexa and Lexapro, and you wouldn't know this, but do you know if there's a commonality between the two?
Isn't Lexapro just a higher dosage of Celexa?
That's a nice way to put it. What it is it's just it's chemistry. It's an isomer. So Celexa was the original one. And so you remember the double helix, that thing, okay? The left and right hand side of things. Okay, so what they did is they removed the right hand side of the Celexa molecule and made Lexapro L, left side, citalopram. So the goal was to get a medicine that was cleaner, more potent, a smaller dose, and just effective. But what's funny is some kids don't do well on Lexapro and do well on Celexa. So again, it's chemistry, it's genetics. What kind of questions do you have about the antidepressants?
I just have a comment. Doesn't Zoloft treat both depression and anxiety?
They do.
Okay.
Yeah, they are for anxiety and depression. They all are. And so you'll see the indications for depression. You'll see the indications for particular types of anxieties, whether it's social anxiety, whether it's OCD, whether it's generalized anxiety, whether it's the premenstrual kinds of dysphoric disorders. That's what they use, the SSRIs. And what happened, which I don't know, I thought it was kind of insulting, but I think it was marketing actually. Prozac, fluoxetine, when it was introduced, it was I think a green and beige capsule, and then it was marketed to the OBs for depressive disorders for women, and they changed the colors to pink and purple. And I thought, well, that's just marketing. But I just thought, just give them what works, and you don't have to change the color. But that's kind of how they did that. So those were the antidepressants. So in terms of your young lady, that may be an option for her along with her ADHD medication. Okay. And that may have to be something that's tracked to see just how cyclic her mood is and where you begin to see that happen. Whether she's ovulating or is it, pre her menstrual period, post her menstrual period. Because they did use it. It has been used where it's used just for those few weeks and then not anymore.
We did, keep kind of like a log, and we started noticing that she was having more of her outbursts before her menstruation would start. And then whenever she would start her period, she would get like aggressive. So maybe like the first 2 days, she'd be very aggressive, and then it would just really fade away right after that. So it was right before menstruation and then the first 2 days of it. And we noticed that it happens every month, and she gets a very aggressive behavior.
Mm-hmm. Yeah, then she would probably be a really good candidate for one of those medications to kind of stabilize that prior to.
Okay,
Okay.
thank you.
Okay. So the other bigger categories that have to deal with mood and aggression are those stabilizers. And there are actually two categories. One category also treats psychosis. The other category treats seizures, migraines. So throw me out some names. What do you know? What do you heard? Abilify. Momento. Resperdal. Lithium. Geodon. Seroquel. Zyprexa. So let's start with the lesser of the two evils, as I call it, the typical mood stabilizers. That's how we categorize them, typical, because they are actually, all of them, with the exception of lithium, are also anti-epileptics. So they're to treat seizures. Neurologists and psychiatrists, we use very similar ones, but they use more of them in terms of treating seizures than we do in treating moods. So you've got Lamictal, you have one called Trileptal, or oxcarbazepine, it's a long name. You have Neurontin. You may see Depakote commonly, or Depakote ER. You also see Tegretol. And some of them require blood work and some don't. Some can make you more sleepy, gain more weight than others. And so the dosing is typically spread out through the day or some at night. And these are really the mood stabilizers to deal with cyclic moods, agitation, irritability, aggression, And those are the meds that if you have a kid like that that's really volatile in terms of stabilizing that, and then if they have ADHD, you can treat that, but you've got to stabilize the mood first. Some require blood work on a regular basis, and so that's really important. So if you don't have compliance with that, there's clearly a risk. You have to check things like liver, the drug levels, you have to check thyroid, you have to check blood count. So those are things that are really important to have to be checked. The lithium is a very old chemical, and it's used to treat really severe depression. It's used with antidepressants. It is the gold standard for bipolar disorder, for mania. It can be very toxic. The levels are required. You can die from taking an overdose of lithium. But it is a very good drug. Long-term, and I get that question, what happens long-term if I have my child on these medications long-term? That's part of the reason why we monitor the blood levels of some of the therapeutic medications, the lithium, the Depakote, the Tegretol. You have to have blood monitoring. But I tell parents you should monitor anyway because their liver and kidneys, you've got these medicines in them. As far as brain effects and other things, we don't have any clear evidence there's anything negative or bad. What's interesting, a lot of the kids are not real compliant anyway sometimes. Sometimes they don't take their medicine, they sneak it, they cheat it, they throw it away, things like that. And so when you check the blood levels for certain ones, you can kind of see where that kind of changes. I had one kid who was on lithium for a while, and actually we suspected that maybe the teeth became weaker and weaker and weaker. But I'm trying to think if I had anybody on. No, actually, I can't really say in the 20 plus years I've been doing this that I've had a person on something and they've been consistent. So they would come off, oh, maybe I have to go back on, or I don't see them anymore, they're adults and I'm not on it. So, but I do have them through elementary or middle school or high school that pretty consistent. Any other thoughts or questions about those types of mood stabilizers?
I have a question in general. Like some medications seem to work effectively from that first fill, and some where you have to take them for a while before they're effective. So how do we know the differentiation of those two?
The only ones that work instantaneously, immediately, are your stimulants.
Okay.
Those are the ones. Everything else has to build up. You have to get to a therapeutic level either by checking blood work or looking at weight. And so it may be, the dose can be based on weight. So what's going to vary from a kid who's 50 pounds to a kid who's 100 or 150 pounds. Certain ones are like that. So, and they take weeks to build up, so you have to again look for compliance, slowly titrating the dose up, getting to a therapeutic level. So you're actually talking about maybe 4 to 6 weeks.
That's a long
Time frame. So, and again, that 4 to 6 weeks may be, increasing the dose every week to get to something that's therapeutic, and then you have to wait.
So what we see a lot of the times is like if they change the medication and we say, well, let's get a month, see what effect that has, and then we're getting close to the summer, and then the parents take them off the meds for the summer, and then they put them back on when school starts, and so, or the parents just say they decided they didn't need the medicine and they stop abruptly, or occasionally I'll get like public aid will stop paying because the kid turned 18.
Right.
And all their medicine is gone. So every once in a while I have a kid that suddenly is kind of stripped of their medicine. And like you say, I know that can't be good.
No, it's not good. Any medicine that requires the process of titrating it, you should not abruptly stop. I mean, your body, we call them lipophilic, so they really stick to the brain like glue. And so it's not good to just strip that away. So there's a process of going up slowly and moving down slowly. The 18 issue, what I've come across now with the state are all the ADHD medicines. The kids are allowed those medications up until the age of 18. I don't want to quote it wrong, but I have a number of kids who, even at 18, are no longer allowed. The state won't cover it. So
Right.
ADHD magically disappears at 18
Right.
for them. So these kids cannot get their medication. So if they want them, they have to pay for them out of pocket. The only way that they can get those medications if they have some specified disabilities the state will allow. Those may be things like autism, developmental issues, so that they may allow them, but that means the doctor has to do a prior authorization.
Right, and that takes a lot of time and paperwork, and the kid then is off the medicine for a long time.
Absolutely.
Yeah.
And the process now, if you call the state and you put in the authorization, you give them history or documentation, then they will review it. But as the physician, we never know if it's approved. They changed the process. So that approval or denial will go directly to the parent. And so unless they inform us, then we don't have approval. Okay. Yeah.
My concern is these medications are also antipsychotic medications. So
Not-
I worry
not
about
that-
side effects.
Right, yeah, so with those, that's the second group. Right, so the atypical mood stabilizers, they are also used to treat schizophrenia. So they are antipsychotics. And they have indications for children for things ranging from autism to treating depression, to treating milder mood disorders, to the bipolar disorder, to schizophrenia. There are 2 that are approved for children, as young as age 6. You know what those are? Resperdal and Abilify. And they targeted kids with autism. And that was their study. Kids with autism with irritability, perseverative behavior, agitation, difficulty with focusing. And so they are approved for children as young as age 6.
But the list of side effects.
Oh yeah, the list is enormous. The biggest issue with the atypicals, that's Resperdal, Abilify, Zyprexa, Seroquel, Geodon. That's the newer list. The older list, and there were just a few that were used in children. Haldol was one. Haldol was used in kids that had severe Tourette's disorder. And some of the older ones that you may have seen or heard of are Meloril, Thorazine, Prolixin, Navane. Those are very old, and so they're not even used in the pediatric population. But one of the biggest things, you have to get blood work on these medications too, not for therapeutic blood levels, but they cause metabolic issues. So these kids can gain weight, they can develop type 2 diabetes, their lipids go up, their cholesterol goes up. So you have that first issue. So you have to measure those things. So you're not getting an Abilify level, but you're checking because all of a sudden this kid has now high cholesterol, his lipids are elevated, and he looks like he's diabetic, and he's gained 30 pounds in 3 months. And that's a problem. So then the other level is then looking at what are the side effects, other side effects that these kids may have. And so the most serious ones we call them EPS, extrapyramidal symptoms. And so this is where you may see a kid whose body tightens up, twists, and contorts, and they tell you, I can't stop it, but my legs feel stiff, or my jaw feels tight, or they're drooling. They come to school and they didn't drool before, now they're on meds and they're drooling like they can't swallow their own saliva. Those are some of those symptoms. The long-term side effect, the permanent side effect of any of the antipsychotics is something called tardive dyskinesia. And that's this oral, they look like they're catching flies. They're constantly chewing, smacking, lips protruding, and pursing of the lip. And those are things you have to watch for. Because if that starts to develop, they really need to come off of those medications. That can be permanent, it doesn't go away. One of the other interesting side effects is called akathisia. It's a restlessness. So the kids say, I feel nervous from the inside out. And they are kind of shaky and jittery and have to move and they pace. And some of the severe symptoms, some of the kids are rolling on the floor or they're walking and they just can't sit still. And they're constantly moving. And you're like, you know what, you need to sit down. What do you do? And then there's complaints, not understanding that it may be a side effect of the medication. Then you're either increasing the medicine or giving them something else and it makes it worse. But it's called akathisia. So the side effect list is akathisias, Oh, my goodness. Easy, okay, I think I got it close. Yeah. Anesthesia. Mm-hmm. You want me to spell it out? You really want me to spell it out? No. All right. So you have to be really careful with that. You can start low. A lot of kids do respond very nicely to some of these medications and those that are really diagnosed with disorders that apply. And so part of the problem that I find is that kids come in and have aggression, they fight, irritability, then the kids go on Resperdal, when that may not be the most appropriate thing. You don't start up here when you haven't worked with something down here. But if the kids are actually having paranoia, hallucinations, clearly, extreme agitation or aggressive behavior. One of the tricky things, before we had some of these, we had kids who had Down syndrome, severe developmental delay, kids with autism, kids who were not speaking. And so then you have this exaggerated behavior. And so what did they get? They got things like Mellorin or Thorazine. Quiet, calm them down, go to sleep. And that's a problem. You don't want kids sleeping, you want them in control. And so the newer agents have some secondary benefits in terms of mood, which is why you see the Abilify commercial to treat depression when your antidepressant isn't working. So they have some secondary benefits, and that's again because of the structure of them. They not all just affect one chemical that flattens a kid, okay? It gives them a little bit of affect and alertness and focus. But you have to start really at a low dose with these medications and move very, very slowly because they are really sensitive to these medicines.
I have two questions. We work at a school where we have a majority of our students are nonverbal who are on a lot of these medications. How can we tell when it's behavior from the medication, the side effect from the medication, or is it just part of their autism or part of their OCD or whatever? How can we tell the difference?
Yeah.
Because we've got one little boy right now.
Okay. That's a tricky question because I always ask, what's the baseline? You know, what is this individual like? And so what are you looking at? Are they hyper? Are they aggressive? Are they a biter? Are they, like one of my kids, he loves paper. He's autistic and he doesn't speak. And he makes a lot of guttural sounds, but he likes paper. So he's looking for paper to tear. So he loves paper. Now, I don't think that I'm going to be able to use enough Prozac, Zoloft, Celexa, Lexapro to get rid of that. That's kind of who he is. That's his nature, and that's his target. That's what he likes. And so we want to just direct him so that he can at least get some classroom work done, and then we give him paper. And then he can tear paper and keep it in his pocket. So the question is, what's the baseline? And what they're looking at. My concern for this kid would be that stimulant medication that may be irritating him. Okay, and my other concern, honestly, and I as a doctor, is the lithium. Lithium is typically approved for kids who are 13 and older. So younger kids, their little bodies, their surface area, and it's going through the kidneys. And so you've got this really serious medicine going through his kidneys constantly. I have some concern. I think there's some, and they may have tried other things. So it's not my call in terms of judgment with that physician. But to look at what the baseline is, and what you're trying to address, I always ask a parent, what's the most problematic behavior? They're a biter. Okay, so then what do we need to do to address that? What's the drive for that biting? And so what are we trying to, so does he need a chew toy? Does he need a sensory item? I think one of the things I look at is what other things we can do besides meds. So if they need some other kind of therapy to redirect. Now, if he's a self-harmer, if he is a biter, you know, there are some, no, he's not. Okay. All right, so then, you know, the question is, when you use the medications, are there certain high-end behaviors that you see that start to diminish or that you can redirect easier? Like I told the kid today, I'm not looking for perfection. I'm looking for just an element of control and a redirectability.
Well, when talking with mom, kind of the behavior escalated when he has a seizure disorder and they put him on Keppra.
Keppra can make them irritable.
And I've had several students who were put on Keppra, and after a while, the parents are like, his behavior's out of control.
Right.
And so, you know, they've had to wean him off of that,
Mhm.
and you gotta be careful because you don't want your kid having seizures on top of it, so.
Right.
And so now we, as a team, you know, we talk, it's like, okay, is this learned behavior, or is, like,
He walks around like a zombie.
A zombie.
I mean, he just, but then sometimes he smirks, and you're like, okay, is that smirk just because he's played us, or is that smirk because he's just seen something else that, but I mean, the whole time you're trying to work with him, his eyes are kind of rolling back and or they're closed, he's drooling.
or like if you present him with a task, he gets very agitated, and that's when we do see an increase in his behavior, screaming, crying.
So there's an
lot of-
avoidant behavior
Yeah,
there.
but a lot
Yeah.
of pacing, he is not content.
Okay.
And, you know, it's just, our heart breaks for him, just trying to figure, you know, because it's like, how much do I as a teacher push him?
Right.
Or is it because it's just the medication and he's just gotta get past it? Or is this truly part of his behavior problem? And we just have to, you know, because we've been modeling for him. So we just kind of rattle off.
Yeah, I think it's really hard to tell. You know, that's not very obvious because he can't speak. My concern, I'm hearing side effects, I'm hearing the drooling, I'm hearing the sedation. You know, and he certainly, I have kids who like play that also tired kind of thing. But you got lithium, you got Resveratrol in there, which could potentially do that for him. And again, he's small, and what's his lithium level, and is he really tolerating medication? Has he ever been hospitalized overnight and the meds stripped?
I don't know.
Okay.
See, this is my first year with him, and I've asked Mom.
Is that coming from a pediatrician, all that medication?
Is he seeing a neurologist?
He's seeing a psychiatrist and a neurologist from over here in St. Louis, because he was just, I got so concerned last week that I called Mom, and she called over here and they wanted to see him immediately. And he was being over-medicated, and they lowered one of his prescriptions. So he doesn't get a noon dose anymore. And I'm like, I was really hoping they'd take him off the list.
One of the questions I have is, you know, are they talking to each other? Because neurologists and psychiatrists, I mean, we sort of followed the same track for a while, and then we split.
Yeah.
And so, and I've seen that with some of my kids who have autism, who have seizures, and the Keppra makes them irritable. There's another one, too, that seems to make them more irritable and more aggressive. And so it's really, really tricky. And I really didn't answer your question. I mean, that's tough. What's behavior and what's medication? You know, are things getting better? And I always try to look at what the kid's baseline is, the high-end behavior first. Can we address that? Because that may take care of everything else that filters down. So if the high-end behavior is aggression, then how do we manage that? But if this kid's having seizures, then my question would be, what is his seizure type? Number two, is he having seizures? Is that some of the sedation or the drooling? You know, you don't know. I had a kid in my office yesterday, and we didn't think she was having seizures. Mom called me and said, you know what, she is more moody, she's more irritable, I can't get her, she won't even let me brush her hair. Mom says to me, yesterday at the appointment, guess what? She's been having seizures at school. She's staring, she's lip smacking, and the teachers didn't inform us. And so I said, well, what we need to do with the medicine that I increased, we need to go back to where she was, because that was managing her base. And then the neurologist had to adjust. So I think you have to look, that's one of the tough things looking at.
I have a question about, like, in the classroom, you've got a kid with some emotional problems that are on some mood stabilizers, behavior meds. At what point, because you want to throw in all these accommodations and make sure,
Yeah.
you know, we're providing, but at what point are we actually, by accommodating, are we feeding into more manipulative behaviors? Where I've got a couple of kids and I know we're walking a fine line and I need a little bit of
What grade do you teach?
high school.
Oh. Cognitive ability of these kids?
One's high, one's low.
Yeah, I think the accommodations, and I run into that a lot, when you've got accommodations, and how much are you adding versus weaning those accommodations, tapering those accommodations to see what they can really do. And it can, because then the kids don't have the skills they need if they want to do something else, and then you wind up walking that, okay, get on disability kind of thing, when maybe some of them may or may not have to do that, but they don't have the skills. Have there been withdrawing some of the accommodations or minimizing? Or is the kid resistant when you do that? Is that?
Neither one of them, well, I guess one's on the spectrum. Not so much, they're just, like, for example, one of our kids, an easy accommodation is reduced homework. And, because she's very capable, very bright, but the guardian has more problems at home.
Oh.
Homework she buys, she's failing number of classes even though she has the ability to do the work. So, you know, we accommodate by saying, okay, fine, we'll.
So you're really working with you're accommodating the parent, not the kid.
It is actually at the recommendation of the psychiatrist, however, you know, he sees her once every 2 months, looks at her grades, oh, she's failing, and, you know, assumes the work's too hard, because that's what she says, but it's not too hard. You know, and then she's, oh, well, they gave me this much, but I'm only supposed to have one assignment a night. And she's extremely manipulative anyway. So I guess at what point do we stop saying, okay, we're not teaching you anything here. You know, we don't.
She a freshman, sophomore?
She is a sophomore, 16. So at what point do we say, you know, okay, we're not doing this anymore, we're not helping you by that accommodation, and all we're doing is furthering the manipulation that you do of everyone around you. No, we're calling you out on this, we're done. However, then how do we know when there really is a need for an accommodation? That's where I struggle.
Yeah, sometimes I ask parents, or the schools to, can we modify this in a different way? You know, is there a homework club, or is there some other place where she can do the homework that doesn't involve the person that she's having the most difficulty with? Can we pull somebody else in because we really feel like in the classroom she can do the work, and to assess that?
She does it with me.
She does it with you one-on-one? How does she do like in small group setting?
So it depends, small groups, not medicated, didn't function, I mean, was highly disruptive.
Okay, so she's can't focus, she can't maintain. So one of the questions that I would have is, if she doesn't have that, if you see that dramatic of a difference on that medicine, and then she goes home, Adderall is probably not there.
Right.
So her ability to maybe sustain her attention with something that requires that much energy is probably that good, so she's going to resist.
Right.
So then, do you think that it could be utilized there, and you start to add things on?
I would like to see that happen.
Okay. Yeah.
So we have a lot of interventions in place, but
yeah. I mean, I think this is difficult. I see kids who have IEPs, and we try to work to, okay, the accommodations, they're not using them, let's kind of pull them away and reduce them. But again, if it's looking at, is it behavior, is it medication helping to modify behavior, and can we get those people around to kind of help? So does that mean you do homework somewhere else besides home? Do you go to the homework club, or you go to the library in the community, you have a tutor, different things that, I have one kid who has accommodations, and we kind of modified the meds. The mom emailed me yesterday and said, you know what, the meds are okay, he just doesn't want to do the work. So this is what we're going to start doing. And so it's kind of one of those things that you kind of look at. And then, I mean, you know, I don't have a good answer, but it's one of those where, okay, we've done this, it's not working, we need to meet with everybody, the doctor needs to be involved, and this is what we see, and so this is what we're going to start doing, and we're no longer going to allow you to do this. And it's one of those.
what about, like, when this girl was not on the ADHD meds in the classroom, like, we would try to ignore the minor inappropriate behavior, you know, the talking out, the off-topic, you know, the exaggerating the lies, all that. We would try to tolerate it and just ignore it. But at what point are we not addressing, you know, when she got out of control and became disruptive, you know, obviously we intervened. But at what point should teachers have stepped in and said, we're not tolerating this, versus you know, as an accommodation, we're always like, okay, let's ignore the minor behaviors, you know, choose your battles.
Right.
That kind of thing. But are we actually feeding into the behaviors by doing that?
You know, I think it depends on the kid. You're not necessarily feeding into it. I think they're going to, depending on where they are cognitively, behaviorally, they're going to up the ante to get the attention that they want. So then the question is, you know, is this girl really impulsive? And so there is a level of poor control. So then the medicine, somebody says, okay, look, let's just do this. And all of a sudden you see that she's a little bit more in control. You know, how much of that in terms of medicine, because ADHD meds can be pretty much like a light bulb, boom, boom. You can see that. But then you still have her personality that you're going to be working with, and, you know, and then finding another option, you know, to not feed into it, then we need to remove you from the classroom and you know, do something different. It's kind of funny when you say feed it, because you try to ignore that and not engage in that. But then, you know, what else do we do? How do we pull her out of the classroom? That takes another staff person away? Or, you know, do we put her in the back of the classroom and turn her desk around to the wall, and would that do it? But I think most kids, in terms of personality, when they're looking for that attention, they're going to just continue to up that until you are in, and then it's out of control, and you're thinking, well, how do we let it get to this point?
So you just stop it when it first
You
starts.
stop it when it starts. Yeah, I feel like it's sort of like a 2-year-old.
Sure.
Okay, and then you kind of address it and to try to do it in a way that you don't escalate things, but there's no perfect situation. So,
Does any medication make a kid less oppositional?
you know, what you see, because there isn't a medicine for oppositional defiant disorder. The ADHD medications in general can decrease the drive for that. And so it looks that way. I have a kid that I work at the school where I was before I got here. Oh my gosh, it's like when he comes in, whew, it's like, this is incredible. I mean, just loud, demanding, argumentative. I mean, he's like this bull in a china shop, literally. Just, he was actually on the news because he carjacked a woman. And he's only 13. And so, but I have him on, just simply on methylene ER. It's a generic methylphenidate. It's an extended release that lasts about 6 to 8 hours. He takes it, and then in about 30 minutes or so, he is compliant. He gets his work done. Yes, ma'am. How you doing? He's cooperative. Now, somebody, and he'll, you know, he still has a mouth on him, but he's controlled. So it's like night and day for him. And for some kids, it's like that. But there's no meds for it.
The idea of a diabetic that can't help it and can't break down sugar is one idea to people. But the idea of somebody with oppositional defiant disorder, the idea that they can't not be oppositional, it's hard to understand why can't they just quit it.
Right, it is. That is, because it's not like, I don't feel like making my bed and whatever. There's this huge drive in terms of annoyance, argumentative behavior, refusal to comply or cooperate. There's this sort of innate, and I always say, look at the personality. And everything's an argument. Everything is, you know, you're not doing it the way it should be done. Everything is, I'm not doing that because you don't know what you're doing. You can't be. Everything is there. And it's not just simply, okay, I won't. It's not there. It's interesting. I always talk about my own kids. I have 4 sons, and 2 of them are ADHD. But the one that is almost 20 is very ODD, and we knew that from the start. His personality was just different than the other 3, just much more of a drive, argumentative, even at 2, refusing to eat because I can't have a granola bar, and just wouldn't give in, and so there was this sort of innate, and he's an intelligent kid. He's a really smart kid, but that personality, that opposition, that argumentative behavior, that the teacher and myself and the teacher are on the same level. It's like, no, you're not. You have to show respect to the teacher. Just that was always part of that for him. So it's not like you have a broken leg or, you know, you don't have, it just, because you see the person and you think, you know what, they're just being, you know. So it's tough, yeah.
Is oppositional defiance, can that be selective? Like, is it,
Okay.
Seriously.
Right, no, I'm
because
serious,
we have
right.
a student that
Right.
clearly exhibits some of those tendencies
Right.
for certain people. He does not have that problem with me. And I'm not special, it just happens to be me that.
You know what, and I was gonna say, yeah, you are. There's some connection there with you that this kid has enough respect for you. So whatever connection you have, use it to your advantage. Typically, oppositional defiant disorder is not necessarily selective. If it's the real disorder, it's not selective. Now, they can sort of draw in and out with that. And so you kind of ask other people, you know, how is he at home with mom or dad? How is he with, you know, maybe a grandma or grandpa, and kind of to see where his circle is and kind of what he does. Now, some kids certainly can be, you know, defiant just because, you know, I don't like her boots and I don't want to cooperate with her.
Right, that's the same conclusion I've come to. His issue is one of respect. He doesn't respect this person, so he doesn't do what they ask. It's not
Yeah.
necessarily.
Right, and that's not something you treat with medicine. That's all behavior. That's all part of how do we work with that. And what does that mean, respect? You know, and how they define it or whatever has occurred. So there are some kids like that. I mean, I very seldom have ever run into kids who are, who will say things to me that they've said to the teachers or the classroom aides or their parents. And it's like, how come you don't say that to me? I don't know. I don't think I'm special. I think it's just because I'm the one that holds the script with the pill, you know, and it's like, I'll give you more meds kind of thing. But, it's just interesting, the dynamic that some kids will have, the connection that they'll have with certain people, and others they won't. It could be a tone of voice. It could be a number of things. So, yeah.
We're only going to have like 10 or 15 more minutes until we're done. And so we want to kind of think about that. One of the things I want to bring up, a couple ideas was, number one, there's not so many child psychiatrists around that if we have a student that uses one, they typically use the same medications over and over again.
Right.
And so that's like, that doctor uses.
You kind of know, right? I have a friend like that, and I know his mark. And
Yeah.
the kids come to me, and I go, oh, you saw him.
Yeah.
And they say, yeah.
The second thing is, for these teachers, social workers, and principals to get to a psychiatrist, they have to send a note with the family to you because they're not coming in with the family. Because when you see the family with the family I saw you with, you can say to the mother how's things at home, and you can guess what how things are at school, but if they don't send a note to you that tells with numbers how the behavior is, you don't really know how the behavior is being affected at school.
Right.
That's a problem for these people.
Okay.
So how would the note to you be the answer to getting more communication with the doctor?
For me, personally, I like to talk to people. So you can send a note, you can send Connor's rating scales, those are important. But I like communication, so that means I want to know what's happening. I want you to tell me, because then I have questions back and forth. Now, that's just me. Notes are fine because you can bullet point and give information, or write a letter, or send an email, things like that. But oftentimes I want to talk to somebody and say, okay, so what happened here? Is this a pattern that you're seeing? So I have kids who they'll bring in their behavior log from school and different things like that. But the communication with the number of physicians that these kids may potentially see, because if you've got a kid who's seeing a certain psychiatrist and a neurologist, and maybe they're seeing a GI doctor, GI doctors use lots of Zoloft, so you're trying to figure out what all is going on. You've got to, it's just.
I guess as an educator, for us, what are some key things that, we need to look in to make sure that the parents are aware when they go back to report to you or the neurologist or, whoever, because they call, I send behavior reports and notes home and I call the parents all the time. And sometimes it's like, I wish I knew buzzwords to tell them that they would clue in, that they know, to pass on to the physicians.
I think you're going to need a release of information so you can talk to the physician. I do. I think that's what has to happen. I think you need a release.
And I have a lot, I mean, my respect for parents is, because, to take these kids and have them 24/7.
Sure.
I just have them from 8 to 2.
Right.
And I have no clue what it's like to take them home and see what they're doing at home. And so, I never want to judge them for the medications that they are putting on their children. It's just sometimes, for me as an educator, I'm sitting here and it's like, okay, I'm not getting anything out of them because like you said, one of these are.
I think what happens too with a lot of my parents, they're very overwhelmed.
Oh, yes.
They are so overwhelmed with maybe this one kid, but then they have other kids or other responsibilities or grandparents. I have grandparents who have their great grandparents. And so it's just overwhelming. And so sometimes for them to say, okay, these are the papers from school, but to remember that, I think that's the other part. That's why I said it's real important that you communicate directly with the physician, especially with the psychiatrist.
I'm just trying to make their life easier and and help them develop the tools that they need because their son is young. I mean, he's going to be around for a long time, and I don't want to see him get bigger, stronger, more aggressive.
Right.
And then when he's 16,
Right. And the other thing, we talk about meds, but I always question, okay, kids are getting whatever therapy, speech therapy, occupational therapy, all of those other interventions, respite, which I don't think there is such a thing as respite anymore. I don't think there's money for respite. But those things, those services that can support the parents. And so if they're in an area that, we don't have access to a lot of resources or we have to go so far out, there's so many resources, it makes it so hard. And I just ask parents to try to get involved in as many things as they can. Go on websites, go on parent sites that are reputable, and communicate with other parents about what things work. But sometimes that doesn't happen. I have parents who just don't have the energy, or they're doing their own thing, or whatever. And so, but I think it's important that, for me anyway, that I hear from whomever is working with that kid at school, or I've talked to some people, the kids who've been at residential. I want to talk to people that are working directly with these kids, even if it is for that 6 or 8 hours. That's an important time. That's their work. And so what's happening there? So, yeah, so the buzzwords, the things you can give the parents, as long as they're in the services that they need to support themselves too, if they are in fact engaged. Because if they have the energy, they'll help them with their kids.
What problem we're facing, we have attendance centers, and the building that I'm at, we have pre-K through first grade.
Okay.
We see a lot, of ADHD.
Right.
We see a lot of ODD, OCD, but most of them go to a primary physician.
Yeah.
And they're not willing at that early of an age to start them on anything.
Yeah.
And you understand that, but then if we feel like they're missing their foundation, if they're missing out on their learning there at kindergarten, first grade, and, so what can we do to help these children? And then there again, a lot of them can't afford, to come to someone like you.
Make the travel or go
Yes,
to.
we're in Southern Illinois, we're close to Evansville, Indiana, but a lot of those don't take the medical card. So what can we as educators do to help these children without the medications? So we don't lose it at such an early age.
Well, my answer isn't going to work, but it's essentially more staff and smaller classrooms. I mean, that's, right. And you need that environment where instead of having 24 kindergartners, split that in two. We have staff, it's just difficult. And I understand that, the primary care doctors, some will treat the very simple, uncomplicated ADHD. But once they go so far, or, they have their standard pick, and sometimes that's not appropriate for little kids. You don't give a long-acting med to a little kid and they can't sleep at night, and then they say, well, I'm not doing it anymore, you find someone else.
Oh, they'll say, come back when they're like 7. Well, fine. but what do we do?
what do we do then?
Yeah.
And a lot of times with little kids, with ADHD, rather than using a stimulant, we'll start out with something like tenants. Okay, to help the hyperactivity, don't have that side effect, and hyper-aroused state, you use lower doses, and it's a little bit better for little kids. Otherwise, you have to use tiny doses of the stimulants, small doses. But some of them just won't, they just won't do it.
That's sometimes a problem for the children that I help get to the psychiatric hospital is when they come back home. The local physician, a lot of times in a small town, refuses to re-prescribe that dosage of medication because they're just not comfortable with medication like that. They're not experienced like you, so their general practitioner, they'll go with ADHD meds and that's it.
That's it, yeah, yeah. And again, you know, that's where, I think it depends on the physician, whether they say, okay, I will consult with this doctor to find out why, what's going on, so I'm comfortable and I can document that and do that. And you know, and I have kids who I have some kids who have real severe cardiac issues, and I say, well, I don't want to prescribe any medicine, I'll talk to the cardiologist. I mean, I think that's kind of what you have to try to do, especially if you don't have resources in the area.
Link them together.
Link them together, right?
We have like 5 more minutes, so I think this has been a lot of very useful information. Probably we could do this again, certainly, because time has zoomed by quickly. But before we finish up, did anybody want to get a question answered that we haven't approached yet today?
And I did want to mention there were some antidepressants that you may have heard of that we didn't talk about. Wellbutrin SR. We have some older kids on that. Cymbalta or Effexor XR. Those are some different types of antidepressants. Just to kind of heard those.
How do you decide as a doctor whether or not to use time release, single response medications as opposed to dose in the morning and dose at noon?
Well,
Could you repeat the question?
oh yes, she wanted to know how do I decide whether to use an immediate release preparation or short acting where you have to dose it morning and afternoon versus an extended release. Well, one, it depends on the age of the child. It depends on whether or not they are naive to medication or not, if they've ever been on anything. And so if I have a child who's in kindergarten, who's never been on anything, and say, well, you know what, let's try a low dose of Focalin. It's 2.5 once in the morning, and let's see how long it lasts and what the adverse effects are. And so if I have an older kid who comes in who's 16 and says, I've never been on these meds either, well, maybe we'll try Focalin, but maybe we'll try 5 milligrams, but I'm still going to do it very small. I was trained to start low and go slow. And so then you look at duration, and you look at making sure they don't have side effects, and you look at compliance and what's convenient. So if this older child says, well, you know what, this works, so morning and lunch, well, why don't we do a sustained release that'll get you through, you don't have to take that noon pill. And then if they're, you know, again, tolerating it, and then they have this afternoon, then maybe we'll go to something longer. And then that's kind of how you kind of work up to that. So if they are naive and have never been on anything, I typically start with something that's short acting. Yeah, for most kids in general, just to see what happens. Because if they don't eat, then I don't want them not eating lunch. So yeah, that's kind of how I do it. Everybody's a little different. Some just like conservative, they just give them conservative. They do. That's one I see it all the time, yeah.
What's the most helpful information that as an educator we can give you to help the child? Like what do you want to see? Do you want like only aggressive behavior? Do you want daily behavior sheets? Do you want a synopsis of the month? What would be the best thing that we could give you to help you in figuring out that?
I like the weekly behavior sheets. You know, when they chart it for the week, and then, so the kid brings it in and says, I got green days. And then for younger kids, I had one yesterday, and the sheet is then marked, I guess, in, what is it, spelling, reading, math, or some do it by hour. And then it's for the week, and then they bring those in. And his had colors on them. So he had all these greens, and then there's a yellow, and then there's a mark about what happened. I like those. I like those, yeah. Because then you can notate it, with something, so it's basically that weekly. So I have a lot of kids who do the weekly. How many points did you get for the week? Oh, I got 35 out of 50. Okay, what does that mean? Where does that put you and why and what happened? So I like that. That's what I like. Yeah.
When you were talking about some of the permanent
Side effects,
Side
tardive
effects.
dyskinesia.
I know a student who's very young, 7 or 8, and comes from a family member has pretty good mental illness. So he was treated, he was on a lot of medications. They pulled him off all the medications because he developed tics. He still has tics, bounces off the wall occasionally. How do you know, I mean, when it's permanent,
Okay,
or
so
do some of those symptoms, will they subside?
okay, so the one that is permanent, the tardive dyskinesia, that's the bad one. That's the permanent one. Now, in terms of tics, my question mark is whether or not it just flipped his genetic switch. Tics are really prominent in kids about 8 to 12. That's the peak time. Kids can have tics. They just, all of a sudden they're sniffing and snorting or they're doing this, and then it goes away. So it's transient. My second son had transient tics. We took him to an allergist and his pediatrician, and we got these allergenic stuff for his pillow and all that, and then all of a sudden they're gone. So tics occur in childhood. Okay, so the permanent one is tardive dyskinesia. So then my question is whether or not with the medicines that this child was on, whether or not there was a propensity for tics anyway, and then you're just seeing that, and that's part of who he is. He has a tic disorder. Now, the other thing, and again, I don't know with this kid, but sometimes I've had kids to be on high doses of medicine, and I start to take them off, and they develop a movement disorder. And so it's a reverse akathisia. So it's not a side effect from the medicine, it's because they were on high doses and their brain is sort of trying to rebalance itself. All the neurotransmitters, and they have all these odd movements and behaviors, and over a course of several months, all that just goes away. So it's something that they're going to have to look at, but the one that's most permanent is the tardive dyskinesia. That's the scary one.
And that's the facial?
That's the facial. That's more of the oral, tongue protrusion, lip smacking, chewing movements, pursing of the lips. It's facial. Yeah, they call it TB.
Any more questions? We're running out of time. It's 20 after, so we only have 10 more minutes until we're gone too. Thank you, Doctor. We're actually going to have a group discussion about having more doctors come back and talk to us more in the future.
Okay.
So I will certainly be in contact with you about that as we learn more about it.
Yeah.
One last thing I'd like for you guys to do on your page that you're going to get back to me with information. Go ahead and write down on that one when you want to have our next meeting. Do you want to have it when school starts right away, a week or two after school starts? Do you want to try to have one before the school ends in May? What is the time when you guys would like to do? And then again, I'll look at the group as a whole, and I'll send out an email to all of you. So we'll have an information on when's the next meeting and what we would like to see as a group to have a presenter. Okay? All right. And then we're done with that. So thank you guys very much for coming. If you have any questions for the doctor, then she'll be here. You can meet her and let me know if I can do anything also to help keep your agency bringing you here. And so if ISRC can contact your school or any of your administration and let them know about our behavior teams, let me know about that. So thanks for coming, everybody. I appreciate it.
What I'm going to do is I'll give you my name and my office phone number. So if you just have questions or things like that come up. So my address is 12 North 64th Street. Yeah, 12 North 64th Street. It's in Belleville, 62223, and the office number is 397-7145.
Can you repeat that, please?
The address?
All of it?
Yeah, 12 North 64th Street, Belleville, Illinois, 62223. Yeah, it's, 62223, yeah. And the phone number is 397-7145. And I'll give you another number because I don't know.
What area code is that?
618. And the other number is the 618-397-0900. 0900. And that's Chestnut in Belleville, on the west end of Belleville. Chestnut Health System.
Email.
Yeah, it's JHALL-DAVIS@chestnut.org. Davis at chestnut.org.
Get the email one more time, sign language.
Do it again one more time in
Yeah.
sign language. It's
Emails?
gonna
Oh,
take-
sorry.
It's gonna take you doing the address one more time in sign language.
That's okay, it's JHALL hyphen DAVIS at chestnut.
Yeah, here's the CPD forms.